Yes, we are live now. Okay. Good morning, everyone, and thank you for joining us today. Today is very special for all of us. First and foremost, I'd like to thank Dr. Mangat Dogra for being with us. Mangat, as you know, was the former chairman of Postgraduate Institute and has done, devoted his entire life to retina, and with his special interest in, for medical retinal diseases, for retinopathy of prematurity, besides taking on, very difficult cases. Thank you, Dr. Mangat, for being with us. And as all of you know, the imaging webinar, which we began almost about 6 to 7 months back, has been drawing a lot of interest because imaging has become center stage to ophthalmology. We're all moving towards consultations that can actually give us even more information than merely just clinical examination. And this importance has not been lost on anyone globally. And that's why we thought we'd start these imaging webinars. And the concept was that we bring you a speaker who has, who's very passionate about their work on retina or any other type of imaging. And today we're delighted to have with us Professor Gemmy Cheung. And thank you, Professor Gemmy Cheung, for being with us. I think many Indian colleagues know her very well because she's been a frequent visitor to our country and has participated in many conferences. And Professor Gemmy Cheung she's currently professor at the Duke-NUS Medical School at the National University of Singapore. She's head of the Medical Retina Department, Singapore National Eye Centre. She also heads the Retina Research Group at the Singapore Eye Research Institute. Her research focus on Asian retinal diseases, especially age-related macular degeneration, polypoidal choroidal vasculopathy, and myopic macular degeneration, all very important causes of vision loss. She has more than 200 peer-reviewed articles and more than 10 book chapters, and has completed several clinical trials in anti-vascular endothelial growth factor therapies. She's received a significant number of very important awards, including the APAO Outstanding Service in Prevention of Blindness Award, the APAO Nakajima Award, the Achievement Award, the Young Investigator Award from the Macular Society, and also the American Academy of Ophthalmology Achievement Award. So really, she comes to us with a tremendous background of research and a great passion for ophthalmology and for saving sight. Welcome, Dr. Gemmy. We're all very delighted to have you here with us, and I'd invite you to give your talk now.
Good morning. Thank you very much for the very kind introduction. It's my great pleasure to join you all, and it's lovely to see many close friends and familiar faces. And it's always a pleasure to participate in events and have opportunities to discuss with many of our Indian colleagues. So I've recently participated and spoken at the VRSI on PCV. So today I will build on that and talk a little bit more generally about choroidal imaging. So I hope my slides are coming up, and these are my disclosures. So the outline of this talk is going to be over 30 minutes in two parts. First is describe and discuss some of the methods for evaluating choroidal features. Some are more established, whereas some others are still in development. And particularly, we want to discuss what are the potential pitfalls and limitations and how we can move these towards more established clinical application. In the second part, going from more dry technical aspects, I'd like to show you some clinical cases, and just to demonstrate how looking at the choroid is really important in some of these cases to actually make the right diagnosis. So going back 2008, of course, Dr. Rick Spade was one of the first pioneers to describe looking at the choroid on OCT, when initially we all just looked at the neurosensory retina and all the way down to the RPE. So he used the EDI method, and subsequently we also have other methods such as using a structural OCT, particularly in eyes with thick choroid. These methods help us overcome the loss of signal or signal to noise roll off as we go deeper into the posterior aspect of the eye, and particularly important with conditions that affects the choroid and make it thickened, or nowadays very popular area area to look at is the pachychoroid. But not only that, of course, in myopia, when the whole eye wall goes posteriorly, it is also very important to have these technologies to look at the posterior curvature. And here we can not only see the RP going backwards, but also the extreme thinning of the choroid, as well as the full thickness of the sclera as well. In fact, these are actually teenagers undergoing atropine, and I was talking to Dr. Nangia just now about patients having atropine, and you can see that with increasing refractive area of myopia, how it changes the whole shape of the back of the eye. Now, as we follow up these cohorts now through their atropine therapy, this is a great opportunity to use this non-invasive technology to progressively understand how the posterior aspect of the eye wall, as well as the choroid and other structures, change with time. Of course, going back to clinical side, also when we look at not just the thickness, but the morphology of various changes in the choroid, we can also identify, or almost some of them are pathognomonic and help us make a diagnosis of various choroidal mass. At the top is quite a homogeneous mass, possibly a secondary tumor. In the middle panel is clearly a osteoma with this kind of tubular cavitation inside, and at the bottom is actually a fungal choroidal abscess. So looking at the choroid with this kind of non-invasive technology is really not only a research interest, but also clinically relevant. Now, coming back to my particular area of interest, of course, there's a lot of interest at looking at PCV because it's been described that these eyes generally have thicker choroid. So thickness is where we started, and that comes back to the pachychoroid. This remains still a very controversial area because the definition is still unclear. From very first notification or the observation that the choroid is generally thicker, because that was really the easiest thing to pick up on a non-invasive OCT, to now more and more sophisticated ways to add to that disease specification, and we'll go through them. So first of all, thick choroid, obviously, and there are some eyes that are terribly thick that we don't even need to measure. We eyeball it. This eye is probably over 400 micron thick. But the question always is, what is the threshold for calling a thick choroid? Is it 270 micron? Is it 300 micron, etc.? And the other thing is you need to have a OCT that can negotiate a thickness and pick up the choroid-scleral interface, whereas in some noisy scans, as you can see in the bottom right, you may not actually be very accurate in that thickness measurement. So this is one of the papers from Professor Rosenfeld's group describing in a normal population with no disease, the range of choroidal thickness in supposedly normal eyes. And you can see, we know that choroidal thickness goes down with age as we go from left to right in terms of age strata. But still, even in the 70 to 79, 80 to 89 group, you can have relatively normal people with a choroid as thick as in the 300 plus range. So they suggested that an arbitrary cutoff is really could be picking up many normal eyes, particularly 300 is probably not that uncommon. And they suggested maybe picking up a threshold at 95% and above of normal would be more accurate, but then that really requires the choroid to be very thick. And our group have also looked at a much larger population in our population study, and the range, as you can see here, for normal is 106 to 447 according to 5th and 95th percentile. So again, I think that reinforces the message that 300 is really not that thick. Plus, another issue with just using thickness is that there can be regional variations in the choroidal thickness, and many of the previous studies used a single cut of subfoveal choroidal thickness, whereas if you can do a choroidal thickness measurement throughout the volume scan, you can see in the map on the right-hand side that there is a particular area of thickening in the inferotemporal aspect, to the fovea. So a subfoveal choroidal thickness, again, is a limitation of not actually reflecting the whole range. As you can see here on the volume scan, the choroid is tubular if you're cutting it through its lumen, and then at the bottom here, it becomes extremely thin. And on the left-hand side is just a snapshot of two areas showing extremely different choroidal thickness. So that is one of the other key limits to using choroidal thickness. This is very interesting, I find, is that we rely very much on the black and white for us to assume what is in the choroid and therefore assume what is in the vasculature. And we assume all the dark areas represent the lumen, okay? So here we can see the lumen is relatively normal, and we can measure maybe 320 micron of choroid and assume there is functional choroid there. But here is actually a case with MP with choriocapillaris non-perfusion, as you can see on the OCTA very clearly. And then when we put on the flow signal and the bottom left, you can actually see while the lumen are all there are patchy areas when there is actually no flow signal. So that is another big discrepancy between the structure versus the function or the actual flow if we're just measuring a choroidal thickness. Nonetheless, it is one of the tools useful for screening. So if we add on to choroidal thickness, looking at Paki vessels is another potentially useful way to quantify or qualify pachycory. And initially, we used to have to use ICGA, which is really troublesome. But nowadays, with on-fast OCT and OCTA, we can get this type of images, and we can appreciate this kind of tubular vessels that kind of course through the posterior pole. They tend to be dilated, and many times we can kind of recognize that characteristic feature, but yet again there is no clear definition. Okay, we roughly know what it should look like, but it is actually very hard, and there are some borderline cases. So here the other issue is that is very interesting is that when we use OCT angiography, all of you who have used this technology realize that when we come to the deep choroidal vasculature, the vessels appear dark, and it's not a hyperflow or bright signal anymore. And it's still really under debate what is responsible for that. And recently we had this again on that case of the MP, very useful case for us to understand. And you can appreciate at the top there was a geographic area of kind of unmasking of the underlying choroidal vessels. Now it looks white because there is loss of overlying choriocapillaris as well as RPE. So the question is, which of those two is contributing to that kind of masking and leading to the black looking large choroidal vessels, which we normally see. So what happened here is this same eye in convalescent at the top, here. As you can see, the choriocapillaris non-perfusion has improved, and at presentation at the bottom. And as the choriocapillaris comes back, we appreciate that on the side of the, sorry, flicking around, the choriocapillaris on the side of this lesion recovers, whereas at the center it was still quite badly ischemic. We appreciate that those vessels appear more dark, particularly in this patch. So it would appear that the choriocapillaris, when it grows over and seems to mask the underlying whiteness of the large choroidal vessels. And using another modality to look at the Paki vessels, we appreciate in the posterior pole this kind of common appearances in the OCT as well as the ICG. But when we look beyond the posterior pole, we look at the four ampulla of the vortex veins. This work done together with Dr. Spade using the Optos ICG. We realize that many of these vessels are connected to more than one vortex system, and many of them violate the physiological watershed zone, as you can see here. So we propose that maybe these Paki vessels don't just represent a transient dilatation within some of these vessels, but they may actually represent chronic remodeling of anastomosis formed between various vortex vein systems, as you can see in this eye with several other examples. Furthermore, again, I want to emphasize the combination of multimodal imaging. So we then looked at the ICG dynamic filling, and we find that many of these Paki vessels, well, not many, some of them, we see this kind of pulsatile or retrograde filling, which suggests that the perfusion pressure is low in this area, almost resembling what we see sometimes in a retinal vascular occlusion. And so in terms of understanding the etiology of Paki vessels and potentially the whole Pachycory spectrum, perhaps the etiology would suggest a big role which is played by choroidal congestion, potentially outflow obstruction of the vortex vein system. So moving away from the large choroidal vessels, we know that it's been described that in a choroid or choriocapillaris, attenuation is also another aspect. And this is again a bit controversial because the initial description was based on a structural OCT, and many authors suggested there appears to be a thinning of the overlying choriocapillaris, which coincide with the areas where we see these large or enlarged Haller vessel. There has been some suggestion or hypothesis that it is one leads to another, particularly this compression theory by the underlying Haller's dilatation to the overlying choriocapillaris. But establishing this cause versus effect is still not clear. Now, the other thing is in terms of the resolution, we know the choriocapillaris is really, really very thin, probably about 10 micron thickness. And in terms of resolution that we can see on the structural OCT, it is really very crude when we talk about observing choriocapillaris thinning. And if anything, it is the OCT angiography using the choriocapillaris lab, which is particularly useful, and many groups have tried to quantify these changes. And I won't go into these and again to overlap the areas of choriocapillaris non-perfusion or perfusion deficit with the underlying Paki vessels. Many of these attempts, but this is a very important area, is to actually, you know, when we look at the OCTA, particularly choriocapillaris, it is like just smudges of black and white, right? And many groups have tried to binarize and measure various things, and assuming all the black areas are non-perfusion and report several results. But the accuracy of many of these methods is really important to get it right before we can accept the conclusion of these papers. In terms of choriocapillaris flow quantification, there are several key areas that can affect, such as the poor signal quality. So most groups, for example, Vasada's group, would recommend that we take multiple images and average it to increase the signal to noise ratio. That helps us with the ingredient to work on. But nonetheless, more importantly, is projection artifact removal. Of course, we don't want any parts of the overlying retinal vasculature to be counted as choriocapillaris when we quantify it. And as well, many of these eyes, particularly if there is RP elevation, even if it's a druce, or more established like PD or PCV or blood, etc., these lumps are going to cause a black mass inside the choriocapillaris lab. And it's important to not immediately assume that all these blackness are due to choriocapillaris non-perfusion itself. So we need to be able to compensate for the signal attenuation from any overlying structures. So these are the concepts. They are very challenging technically to do. So although those three criteria I've mentioned earlier on are the more traditional, and increasingly we've moved away from just using choroidal thickness because of the limitations that I mentioned, I just want to mention two other aspects which are increasingly kind of incorporated. And one is choroidal hyperpermeability. As you can see in this eye with PCV on the left eye, quite dilated vessels, but it is really important to look at the late phase ICG. Then we appreciate actually very marked choroidal hyperpermeability, not only in the PCV eye, but also in the fellow eye as well. We observed this clinically on ICG for a long time already. However, there's still an active area of research because it's still unclear what causes this hyperpermeability. The hypothesis is, or often is assumed, that it means choriocapillaris ischemia because it kind of conveniently ties in with that inner choroidal perfusion deficit in item 3 just now. But when we look again with multimodality, with even the en face OCT, with or without the angiography mode, you can appreciate that these areas of hyperpermeability often overlie the Paki vessels. That's quite true, but they are not limited to the areas directly overlying the Paki vessels, but they also affect the surrounding stroma. So there is now another theory that suggests that maybe when the vessels are dilated, they become not watertight, and there is leakage all over the place around it, and leading to kind of pooling or staining in the surrounding stroma. So this is an observation that I would say still needs a lot of research to understand what is the cause of it. Now, that already brings us into the issue of choroidal lumen and stroma, and there is now has been so much emphasis on looking at the lumen, looking at the vessel dilatation, but really there needs to be more work to understand what is the changes in the stroma. One of the methods that has been described is using choroidal vascularity index. So this is basically outlining a slab of tissue with Brooks membrane at the top and choroid scleral interface at the bottom, taking this slab of tissue and then binarizing it, forcing each little dot into dark or white pixel. Okay, so where you cut the threshold is very important. If you've got a noisy scan, you may the value that is generated can be very different. And then we assume that all the dark areas represent lumen and all the white areas represent stroma, and we can quantify how much lumen is in that choroid by generating the lumen over total area. Now, in the past, we've only been able to do this by extracting the image, putting it into image J, and generally we just use a single subfoveal choroidal cut. And we've reported, this is together with Rupesh, and Jay Triplani is another very active user of this algorithm. We've reported that in eyes with AMD that there is a lower choroidal vascularity index, which seems to suggest a kind of certain level of choriocapillaris or choroidal ischemia as the background of AMD. However, same as the issue with thickness, with this CVI, again, if we just look at a single subfoveal cut, it is highly underrepresentative of what's happening in the whole macular area. So recently, we've had the opportunity to work with TopCon on a kind of experimental algorithm, which now the machine can automatically delineate the choroid-scleral interface. Okay, it gets it right most of the time, but it still needs a little bit of manual adjustment. But once it's done, it can actually do that in a much faster manner and go through the whole 6x6 macular cube instead of just manually drawing this line on the subfoveal cut. And once you've done that, you can have a choroidal thickness map over the whole posterior pole. And once you've got that, you can then apply the binarization system and generate a choroidal vascularity index of this whole area. And here you can see that you can actually slice and dice this whole area into 36 little grids. You can represent it in ETDRS rings as well. And we reported the value, as you can see here in this grid, roughly 50 something, 60 something. And this kind of value, if you imagine, that means about, if you eyeball the choroid, about 2/3 of it is dark and 1/3 of it is white, which is kind of in keeping with our clinical experience. And another group of Professor Rosenfeld using the Zeiss machine has also reported similar kind of values of about 55 to 68% of the choroid being occupied by vessels. So this is something new, okay? I think it is not mature yet. We still have to improve on the performance on this system, we still need to validate and making sure that the black and white are really what it is and not artifact. But here are a couple of examples how we can use this method to try to understand more aspects of eyes under treatment longitudinally. For example, this is an eye with PCV that has received aflibercept, showing you on the left-hand side the baseline, month 3 and month 12 images. You can appreciate the choroid has become a lot thinner and overall whiter. There is much less blackness, and we can appreciate that even by eyeballing it, and indeed we can now quantify this. On the right-hand side, this is the reduction in thickness in the blue bars, as well as the reduction in the choroidal vascularity index in the orange line. As opposed to this other example, again, significant reduction in the thickness, but still most of the choroid looks relatively dark. So here we have a reduction in the blue bar, but the reduction in the CVI, as shown in the orange line, is much less. Why do some eyes behave in one way and some eyes behave in others? It's still something that we don't understand, but at least having this new tool will hopefully help us understand the situation better. So we then move on to the second part of the talk, which will just look at a few more clinical examples. I'm sure all of you are familiar with the various clinical entities that have been included into the pachychoroid spectrum of disease. Just want to highlight that increasingly FCE, focal choroidal excavation, has been kicked out because this now appears more and more to be an inflammatory condition rather than a primary choroidal congestion problem. So the schema of things has also evolved with time. So now we have a little bit better structure. Instead of 5 or 6 conditions, 1, 2, 3, 4, 5, there is a kind of natural evolution. So all of these conditions have a pachychoroid phenotype, which is shared and demonstrate those features that I've gone through just now in the choroid. In addition, in terms of disease manifestation, they can be uncomplicated, or they can have non-neovascular complication or neovascular complication. And we group those conditions according to this schema. In addition, according to the level of activity, each can also have without fluid or non-exudative, so pachychoroid pigment epitheliopathy, of course, but even think about now with OCTA technology, even PCV, we can catch it before exudation appears. So you can have non-exudative pachychoroid neovasculopathy and PCV as well. So this is an example when there is no fluid, there is a little bit bumpy RPE, thickened choroid or dilated Haller's vessels, but an OCTA can immediately differentiate a non-neovascular versus a neovascular pachychoroid eye. Whereas when there is fluid, similarly, in addition to fluid, of course, there's double layer sign, but again, OCTA can differentiate in CSR on the left from a pachychoroid neovasculopathy on the right, and sometimes even PCV on the right here as well. So just to notice that all of these, they all share those choroidal features we've talked about just now. Now, going to a few more interesting cases towards the end of the talk. So here is an eye with clearly thick choroid, and one of the issues that that I accept is that pachychoroid seems to be applicable to everything, and it's important that it is now easy to appreciate these choroidal changes, but also to just step back and think, and also employ multimodality images to think hard about differential diagnosis. You could easily put this case or this eye into a pachychoroid pigment epitheliopathy. You can see on the NIR the mottling associated with it. But her left eye was much more severe. Definitely there's thickened choroid, there is dilated vessel, but this is so marked, there is elevation of the RPE as well. So when we look at the ICGA, you can immediately appreciate this is not a simple pachychoroid case. In fact, this is a diffuse hemangioma, showing left eye like this, but also right eye like this as well. It is unusual. She doesn't have Sturge-Weber syndrome, and she is quite asymptomatic to have it in both eyes. But I think just to use this case to highlight that although we've got very nice OCT nowadays, but not to forget the traditional imaging modality. So ICGA is what helped us make the diagnosis in this case. So here is another case, could go for CSR. In fact, this is the patient that was referred in having been treated as central serous. Elsewhere, definitely there is thickened choroid, so thickened that this with the Heidelberg system, you can't actually see where the choroid scleral interface is with overlying shallow SRF, and sometimes with chronic CSR, you may indeed have intraretinal fluid as well. So far, it's in keeping. But in the fovea, you can, or in the macular region, you can actually see this elevation and a very dark shadow. And again, using ICGA, this is not just a CSC, but it is actually the fluid is secondary to a circumscribed hemangioma. So many other conditions can give us the appearance of dilated vessels and thickened choroids. So sometimes just step back and think of the others. This is clearly the Koyanagi-Harada syndrome disease, and I won't really go into this. This other case, unilateral affecting the left eye, again, relatively thickened choroid, again with subretinal fluid and intraretinal fluid. Could it be stress-related central serous? On examination, there are some atypical features. There are these white blobs here, which we don't expect from central serous. And on the ICGA, we can clearly see multiple dark lesions, and he turned out to be Mantoux, very, very positive, and it's a TB choroiditis. How about thin eyes? Can you have PCV with thin choroid? There's this funny debate, and this is clearly an eye with typical features of PCV on the ICG, as you can see on the right, but on the OCT, again, the features in terms of the sharp peak PED, even like a ring-like structure sub-RP, double layer sign, these are all features of PCV. And yet, look at that choroid. It is so thin. On the left, you can also appreciate a tessellated fundus. Why is that the case? So is this case Pachycory PCV? So in fact, the vertical scan shows us this is a PCV which is occurring at the edge of a posterior staphyloma. This doesn't show so well in the horizontal scan, but in the vertical scan, you can clearly see that. So just to highlight that, with ICGA, we kind of lumped every eye with a polypoidal lesion as a single diagnosis, but if we add on the examination from OCT, looking at the choroid and the posterior wall structure, we can actually separate those pachychoroid or AMD-like PCV, which is most typical, from this kind of rarer secondary PCV. And it's been described that these PCVs can happen at the border of inferior staphyloma, or with tilted disc syndrome, or other types of macular bending, and various etiology as to alterations of the blood flow in the choroid has been suggested. This is another case showing you clearly at the edge of the staphyloma and very thin choroid. And similar kind of macular bending, we know that serous detachment can occur on top of dome-shaped macula, and occasionally they can have neovascularization and exhibit polypoidal structure as well. As you can see, again, you can see this sharp PD double layer sign, and yet the choroid just doesn't fit. And so when you see this kind of cases, just step back and think. I think in terms of how we treat them, they tend to be less relentless in terms of the need for anti-VEGF therapy. And possibly with that kind of background, PDT is not the best choice because the choroid capillary is already not healthy. Another secondary cause of PCV is on top of a nevus. Again, if we look at the ICG, it would be a very standard appearance, but it is important to look again at the OCT, and you can appreciate that, in fact, you can appreciate the choroidal nevus on the left-hand side and the relatively thin choroid. Just one more case, the original description by Dr. Spade. So with that, I would just end my talk. I've gone through some of the methods and newer algorithms for us to, as tools to add to our armamentarium to investigate the choroid. I would say despite the newer, fancier and fashionable modalities, it's still
Gemmy, we're not able
to combine all the modalities and use, and not to forget our traditional modes such as ICG or even structural OCT. In addition to understanding and as a part of research tool, I've shown you, hopefully the cases I've shown you shows you that looking at the choroid adds to our ability to be precise in our diagnosis and also in understanding disease-causing etiology. So thank you very much again for the opportunity for me to share. So what do I have to press now?
Thank you. That was tremendous. Actually, there was so much to learn from that, and we know that there's going to be much more coming for the choroid. And I'd like all of you also to meet Dr. Rajiv Raman. Rajiv joined us a little late, and I couldn't introduce him to everyone. And Rajiv, as you know, is a senior consultant in Sankara Nethralaya, and he's been my partner on this program for the last several months. Rajiv, would you like to begin to ask questions? Rajiv? Could you take on the questions and begin the discussion?
You're not audible.
You're not audible, Rajiv. Okay. Can we ask Dr. We can't hear you, Rajiv.
Yeah, the network connection is a little poor.
Not able to hear you, Rajiv.
Can you hear me now?
Yeah, now it's a little better, but your face is
Yes.
Okay, it's a little better now. Not able to hear you.
So my net connection is a bit poor. I'm from the hospital connecting.
Okay.
Please continue.
Okay. Dr. Mangat, would you like to then help with the discussion?
Yes. Great talk, Gemmy. Enjoyed it. So much happening in the choroid, which is in fact the new area for all of us to look at. And I think there are several things which come to mind, and especially when you talked about the thick choroid and the thin choroid, especially as far as the PCV is concerned. So what my question for you is, and many may like you to answer that, is it possible that if we have a thin choroid, like in myopes also, there, whether it is a choroidal neovascular membrane there or other things, that their treatment may not be that aggressive as compared to the other where choroid is thick. So what is your viewpoint on that?
I absolutely agree with you. I think that's something that we must look at. And currently, we don't really have the data. So for example, if you look back at Everest 2 and Planet, the inclusion criteria is purely based on ICG, demonstrating the presence of polypoidal with any sort of active fluid. And we know that when we compare these series of PCV versus AMD, there's always been PCV slightly higher than AMD, but there is always an overlap. And now when we see this kind of cases, I wouldn't be surprised if some of those eyes with thin choroid are actually this kind of secondary cases. And first of all, in terms of etiology, probably they are not AMD in terms of the etiology. They are some sort of mechanical problem. So in terms of the need for VEGF suppression, I would imagine it is less. So we currently don't have the data. We really need to go back to mine that data set from clinical trials. And secondarily, if you imagine if they've already got a thin choroid, I can't imagine shining a PDT on it is such a good thing. Thirdly, when we kind of extrapolate from those serous detachments from, over dome-shaped macula, those fluid come and go. Sometimes they just spontaneously get better. And some other times people inject PDT and nothing touches it. So sometimes maybe these cases just don't actually respond to any of the anti-VEGF or PDT either. So I think now that we appreciate these differences, it is really important to bring it back to the clinical relevance, like you said, Dr. Dogra, and maybe future trials can recruit and stratify according to these characteristics in addition.
In the same area, I would like to ask you another question, because we know that there are certain cases of PCV, they'll do anyway very well. So others, they may not. So we have a group of patients, even if we have not treated them aggressively, they do well. They remain all right. So we don't understand why it happens. Is it something also in the choroid related? Because they look clinically similar. But is there something in the choroid in such cases that we have to look at, or we need to sort of treat them little differently?
Yeah, that is always something that I suppose particularly relevant to PCV that we hope that studying the choroid can teach us. So far, I think the evidence have been conflicting. Initially, particularly with ranibizumab monotherapy treatment, there have been several case series which suggested that eyes with thicker choroid respond less well to ranibizumab monotherapy. Then subsequently, using ICGA, there are other studies which suggest that when there is hyperpermeability, they respond better to PDT containing regimen. We've had the opportunity to evaluate the Everest-2 data set in terms of imaging biomarkers, and the only choroidal parameters we had was choroidal thickness, unfortunately, and that didn't actually come out positive. What was positive was total polypoidal lesion area, so i.e. very juicy, very big polyps. So those respond less well to ranibizumab monotherapy. But so far, I think the evidence of choroidal features in terms of predicting treatment outcome is still inconsistent.
Gemmy, could I ask you that, because you brought up this issue of choroidal thickness in association with choroidal neovascularization, we find sometimes that in myopes, you have a CNV, it's often subclinical, and you may just find one or more, fugue spots in patients who actually never come to your hospital ever, and they're still doing all right because the fovea has not been involved. And also that some of these patients tend to respond very well to just one injection of anti-VEGF, and so has that got something to do with the fact that the choroid is extremely thinned in such patients? So there is a mechanism for the CNV to develop, but that it's not being sort of nourished by or whatever by a thin choroid that you find in these patients.
Yeah, so the etiology, pathogenesis, as well as treatment response in myopic CNV is a whole different area compared to AMD, very, very different. And as you mentioned, Dr. Nangia, it's really important that we don't just immediately translate everything we do from AMD to myopic CNV. So definitely the choroid is so much thinner, and from the clinical trials, we know that on average, they may only need 2 to 3 injections over the first year. That's definitely true that they have a lower VEGF need. In terms of maybe more interesting is to look at the underlying etiology. We propose that in AMD there is a primary choriocapillaris degeneration, and therefore it is a localized ischemia, and therefore maybe the VEGF drive is much stronger. The RPE also expresses VEGF, whereas I suspect in myopic CNV it is much less that case. Half of it's probably the mechanical aspect with lacquer crack, and so I think that also explains why the treatment need and the responses are different.
Gemmy, I have a question. In cases of CSRs which move towards chronicity, how many percentage of cases do you observe a CNV, and in what way would you manage those cases?
So I don't have the data. We're doing a bit of a longitudinal follow-up. Of course, if we just do a snapshot, the day we bought the OCTA, we went and scanned everybody. Then that was the prevalence at that point, but we don't know how many of those CSR progressed to have an incident CNV. Maybe, if I digress a little bit, what we found is that we've scanned the fellow eye of our patients with unilateral AMD and PCV, and about 1 in 5 have one of those harboring a non-exudative CNV. And when we've now followed those up for about 5 years, and the overall conversion to exudative rate is again about 1 in 5. So it's low, but it is definitely much higher in someone who doesn't have a non-exudative NV in the first place. And going back to you were saying, how do I manage those lesions? So those CSR cases, when they have a overlapping NV, first of all, depends on whether they have exudation or not. Like what Dr. Nangia said, even with myopic CNV, sometimes they're scarred up in the full spot. And what we find is on the OCTA, you can often still observe a network, but it's not active. So if it's not active, not leaking, I generally don't treat them. But if it is leaking, then it's very tricky, because there is double pathology in those eyes. It could still be, it of course could be the NV that is leaking, but it could still be the CSR aspect that's causing the fluid. So I would discuss with the patient. Generally, it's not very scientific, but it's much faster and cheaper to give a Avastin injection than PDT, because it is much more expensive. But I would, when I counsel this kind of patient, again, in terms of expectation, is completely different from AMD. AMD, I like, as the word go, tell them you expect 8 to 12 injections in the first year. Whereas this kind, I'd say, we'll try. It may not work. I'll try you for 3. If it doesn't touch the fluid, we may stop, or we may change tact and consider PDT.
Thank you.
Many times they are not responsive to anti-VEGF therapy also.
Sorry? Some cases do respond to anti-VEGF therapy. Yes.
Yeah, not all. Yeah.
There is a question by Dr. Atul Ursekar, and he asks if you have any comments or observations about value of pachychoroid thickness asymmetry between normal and affected eye, actually, or when there is asymmetrical disease.
We've actually, in that ophthalmology retina paper that I've mentioned in the talk, when we studied the choroidal thickness in our population, we did also look at the symmetry between the two eyes. Overall, people tend to be pretty symmetrical, over 90%. So if it is asymmetrical, we didn't actually have a lot of data to dig into why, whether they're actually kind of anisometropic. But certainly, this is a very interesting area, and I've got a couple of patients who have very different choroidal feature in the same patient, and then the thick eye had PCV, and the other eye had a non-exudative neo, which so far hasn't turned into PCV. And you just wonder if, and there is always this theory, whether the choroidal background shares some sort of either genetic or environmental factor that makes the choroid thick, gives the phenotype of the pachytrusion, as well as when they get neovascularization, they tend to have the PCV subphenotype. But so far, we are still investigating that. There is a particular SNP that has been reported, which is the Viper 2 SNP, which has been reported to be associated with thicker choroid. So we're trying to work with some international collaborators to see if we can validate
that. Just a simple question that that when you have a disease associated with pachychoroid and you treat the disease, you do expect a decrease in thickening of the pachychoroid.
So we know that when we inject with anti-VEGF, multiple series shows that the thickness comes down, like those 2 cases I've shown you. Whether it shrinks a Paki vessel is what we don't understand. So when the thickness comes down, what it means, then with CVI, we can then interrogate that further. Is it the vessels that come down? Is it the stroma that come down? And we've seen that in different eyes, there can be predominant change in either. Okay, so then the question is, does any of these treatment, whether anti-VEGF or PDT, can shrink the Paki vessels? That was the initial hope. And yes. With the new theory of intervortex anastomosis, it would appear that these are tubular structures that have formed. They took years to form, like a tree trunk changing its shape. And once it's formed, it's not so easy to shrink it down. It's not a transient dilatation, chemical thing that there's a lot of adrenaline bathing the area and you shrink it, it will go away. I think that's where we think our new finding or new hypothesis about the anastomosis is particularly meaningful in terms of what clinical expectation we can expect to how we can change this, and whether actually is there any treatment for pachychoroid itself.
In that context, I would like to ask one question. So you've done so much on the choroid now imaging. So in future, what is going to be really happening? Is it the choroidal thickness, choroidal vascularity index, or looking at these individual layers of the vessels, which is going to be more important? Or is it going to be variable with the disease pattern? Because these are the things which are, so many of these things are coming in. So what do you think, which one is going to be more important?
I am guessing, I don't know, but I'm guessing it's going to be hyperpermeability, because here we've got various features that study the structure and others that study the function. And generally, I think functional changes are more meaningful and possibly more amenable to therapy than established structural. So at the moment, I place my bet on choroidal hyperpermeability.
So Gemmy, sometimes you have these what we used to call as drusenoid epithelial detachments, and there's no fluid, but you're so scared that even though the vision is good and you keep on following the patient, you see some changes, but you're so scared that is it a choroidal neovascularization that's keeping quiet actually. So what is your experience with these type of patients? Is there a real choroidal neovascularization? Do we need to do any tests to just say that, okay, there is something, it's keeping quiet, we may not treat right now, but we may just keep on follow up?
I think the simple answer is still I will rely on whether there is fluid, subretinal fluid on OCT. Yes. But nonetheless, there occasionally can be a little cap on top of these kind of drusenoid PED. What OCTA has shown is that, in fact, some of these drusen or drusenoid PED can also be vascularized anyway. So, and if there is definitely no fluid, we wouldn't treat. So, so it actually goes back to vascularized or not. I would still use standard SRF and IRF to guide my treatment.
Can you hear me now?
Yes, much better, Rajiv.
Yeah.
Great talk, Professor Gemmy. It was really a great talk. Just one question, like now we have for central serous retinopathy, we have eplerenone. Do you feel, because that has effect directly on the choroidal vessels, do you feel that that may have a role in other pachychoroid spectrum as well?
Actually, I don't know. I have had very little experience with eplerenone, and we've actually not had the opportunity to study choroidal changes after that. But that is an interesting idea.
In India, we have started using more of eplerenone because of the problem on the PDT. We are not having, PDT is not readily available today. That is the biggest problem. And in CSR, especially these chronic CSRs, our options are very limited. So more and more people are now prescribing eplerenone. So probably because that, Dr. Mangat Dogra, what you feel, because now the options are limited. PDT in India is little problematic. Hardly there are 2-3 machines.
Exactly.
Yeah,
I think
I agree with you. Because first of all, we are also facing supply problems with tissue dyeing. Plus, PDT is always expensive anyway. And I was just going to say that despite the negative results from the Vichy study, there is still a feeling that maybe the inclusion criteria or the heterogeneity of the pool of patients maybe was just not adequate to show the potential benefit of eplerenone, maybe in a subgroup of patients, maybe not in every patient. So I wouldn't actually stop using eplerenone. So if you're using it a lot, I'd look forward to learning from you whether you see any change in choroid.
Yeah, I'm trying to do ICG pre and post now. So let's see what we find. We are getting some of them.
Yeah, and that ICG I think is still very useful, although we've also like advocated using OCT to diagnose PCV, but really I think it would be sad if we stop doing ICG. There's still so much information there for us to learn.
I agree with you. I agree with you.
And some of these cases where we have used eplerenone and we have already given for, let's say, 3 months, and very little if it is happening these days, what we have started doing is, of course, we have used earlier also without even looking at a network that you give one of the anti-VEGFs. So what which was surprising in some of these cases, which had more of cystic change intraretinal fluid, aflibercept did work despite not having even a network there. So which was surprising. And because since there is, as already Rajiv said, we had no choice because there's no PDT, so you have to try out something. And some of these patients are desperate. Maybe they have already had one eye, which is very, very poor vision, and other eye, they are desperate. So I think it did work. I don't know how it worked, but aflibercept in some of these cases with cystic change, it did work. So I don't know if you have any experience of that.
No, I haven't, but that goes back to that aflibercept does thin down the choroid quite a lot. Whether it does something to reduce the congestion is something that I suppose a clinical trial, even a pilot trial would be very interesting. Of course, that goes against the traditional teaching of anti-VEGF is used for neovascularization, if there's no neovascularization, but it could be a different modality of action.
Yeah, even I have seen few cases, few unusual cases which were not responding to anti-VEGFs, and the newer molecule, the brolucizumab, worked very well in those cases. So you have any experience to share with brolucizumab?
No, it's not approved in Singapore yet. You've got it approved already. Yeah.
Yeah.
There is
the
approval
cases
for
were really crazy.
but
they were not responding.
rest is sort of off-label, but AMD it is approved.
I think we have another questions from Dr. Atul Ursikar, and that's what are the common imaging artifacts to be noted in evaluating structural OCT and OCTA choroidal imaging?
Masking is the first and most important, I would think. You can see all those eyes with blood, with PED, pigment. There will be a whole streak of black that goes all the way down to the choroid. That's one. Second is in eyes with very thick choroid, we often also get a suprachoroidal effusion, particularly in eyes that are 400 micron and thicker. There is the brown structures which are supposed to be the vessels, and then there's often a puddle, like a thin sliver beyond it. So when we pick the choroid-scleral interface, it's hard to decide where that is. The other issue is that sometimes between neighboring areas there may be a very big dilated vessel, and then the choroidal scleral interface goes down, and then right next to it, it can be 100 micron thinner, and where it goes back up. So to carefully track that very localized variation, and then to derive a value, particularly if we're using a single value, is going to be difficult. But of course, if we can then get a volumetric and average out those, it helps, but still it's got advantages and disadvantages. Averaging also hides the localized variations as well. I think those are the main artifacts that or pitfalls of measuring choroidal thickness that comes to mind immediately.
I have one question, Jamie, very basic one. Being an old timer, I'm not talking of a hazy media where we still use ultrasonography to image the choroid, but in case we have clear media, is there any role even in today's time to use ultrasonography to image the choroid? Because that is what we did even for our patients with the VKH, our patients with so many other diseases in past. So do you think there is still a role for that, or it is all gone to something like swept source OCT?
I think the main issue is just the magnification, because the image is so small, and so the scale is limited on the ultrasound. I think that is the main issue.
Okay, thank you.
Anything else, Dr. Mangat, Rajiv, Sarang? I think we don't have
I think
any other questions. Yeah, Sarang? You want to say
probably
something, Sarang?
measuring the height of choroid, that may be a biomarker in follow-ups. Like probably if you are talking about the functionality of the choroidal vasculature. So functionally, if there is leakage or if there is increased thickness of the choroid, that may be a early biomarker that something is going to happen to the choroid, that it's going to be more leaky and eventually leading to retinal edema. So maybe some additional information we might get in following up the choroidal thickness of the patient. So it could be an early biomarker or a, something like that.
I think one message which I got, very good message from Professor Gemmy. I never tried looking at the flow, which you showed very clear. We always look at that there is thick choroid, but looking at flow, that really is there an increased flow or these are dark ones? I think that is something
Yeah.
I'll start looking immediately. I never did that. It was a good that your OCT which you showed, it was beautiful, which showed that though there was patchy, but there were areas where there was no flow at all. I think they may have some significance. Have you tried looking at, is there any significance correlated that with clinical features?
Not yet. We haven't looked at that yet.
But that is worth looking at. It's a beautiful feature you showed.
Thank you.
So thank you very much, Dr. Gemmy, Dr. Mangat, Dr. Rajiv, Sarang, Prabhat, everyone, and thank you to the audience. I think that it was truly a wonderful talk that Professor Gemmy gave us today. And there is a lot to learn about the choroid. I think that it's opening up a whole new world because initially I remember that when we first studied the choroid with enhanced depth imaging, we thought that we were sort of breaking barriers in science or something like that. And now we see that there is a long way to go in understanding the choroid, and that simply the subfoveal choroidal thickness isn't going to be enough. You need maps and the vascularity index and ICG, everything to really understand the choroid. So thank you very much, Gemmy, for being with us today. Once again, it was a wonderful talk. Thank you.
Thank you. It's my pleasure. See you all. Take care.
Thank you. Thank you. Bye-bye. Bye.
Thank you. Thank you. Thank you.
Thank you.
Bye-bye.
Bye, Gemmy.
Bye.
Bye.